Hey guys, welcome back to my channel, The ENT Resident. Today, our topic of discussion is going to be about the post-operative care and the complications related to rhinoplasty. In my previous class, we discussed the rhinoplasty procedure. We talked about specifically the closed rhinoplasty technique. Today, we'll follow it up with how are we going to take care of the patient in the post-operative period and what are the possible complications that could arise in the patient. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. So, post operative care involves you not only just advising the patients on following certain advice, but before that, it starts even in the pre-operative period, where when you are counseling the patient regarding the surgery that they are about to undergo, you explain to the patient about what is it that they are going to be expecting after the surgery is done, so that mentally they can be prepared about it. So you should be explaining to the patient that there may be slight oozing of blood stain secretions from the nasal pack. They can have some amount of middle ear discomfort, some dryness of the mouth because of the nasal packing. So when you put nasal packing and it's there for 48 to 72 hours, the patient is having to breathe through their mouth. So they will experience dryness of the mouth. And even they can even develop swelling of the eyes as well as the face. So if you inform them in the preoperative period while you're counseling the patient, that will actually take care of unnecessary anxiety of the patient. So if after the surgery, if they have not been explained to it about this, they can suddenly feel very anxious when they see these little things developing. So, and even like say for example, because of the nasal packs, they will have some discomfort in their nose, but there will be no pain. So these are all things that you explain to them right during the time of counseling and taking their informed consent. Next, let's talk about what are we actually going to do in the post-operative period. So in terms of position of the patient, we will place the position of the patient in a propped up state. Why are we doing the propped up state? Because it will help you in reducing the post-operative oozing as well as the edema that can happen. So the edema, there can be edematous swelling around the eyes and discoloration around the eyes as well, which is one of the complications that we see. This generally starts appearing within a few hours after the operation. So, placing the patient in a propped up position will help in reducing this post-operative oozing and edema. Second is we'll apply some ice cold compresses or ice packs over the eyelids for at least the first day. This will this will also help with the swelling and the edema. Now, the eyes compress, you have to be very careful. When we were finishing up the procedure, we discussed about how we place the plaster of Paris cast. So, we have to be careful that the ice compress doesn't soak the plaster cast. So, using very small ice packs is very ideal in these cases. Coming to diet, what kind of diet will the patient have in their post-operative period? So we'll start off with liquids and then slowly soft diet for about 2 to 3 days, and post that they can continue to have their regular diet. Now, the reason why we are starting off with liquids and keeping soft diet for a couple of days is because it will help in reducing the movement of the soft tissues around the nose. So we have put a splint, we have put a plaster of Paris cast. There's a lot of things that have been done around the nose, a lot of things that have been manipulated. So if we reduce the movement of the soft tissues around the nose, which can happen because of mastication, this will actually prevent the loosening up of the splints. So that's about diet. Next, coming to certain medicines. So anti-inflammatory drugs will help in reducing the post-operative swelling. We usually prefer giving NSAIDs or enzymes. Next, prophylactic antibiotics. This is also something that is recommended to use prophylactic antibiotics for at least 1 week post-operatively. And if the patient has a lot of pain, giving analgesics, especially for the first day, it might be helpful. And we tell the patient to sleep on the back, because if they are sleeping on the sides, the splint can get pressed and they may not be aware about it. So it is preferable that they sleep on the back. Next, coming to all the packs and splints that we have applied. So nasal bolster. So after you place the pack inside the nose, we place a little bit of a gauze piece underneath the columella. That is the nasal bolster. Now, this nasal bolster has to be changed whenever we find it that it has gotten soaked. But when you're changing a nasal bolster, you have to be very careful that you do not end up disturbing the splint or the columella region. Next is nasal packs. So we have placed nasal packs internally. If we have only done rhinoplasty, in that case, these nasal packs have to be removed after 48 hours. And if we have done septorhinoplasty, in that case, we will remove it after 72 hours. So that's about nasal packs and nasal bolsters. Then we also have the external splint. Now, the splint that we have put has to be removed sometime between 7 to 10 days, depending on the degree of the swelling that the patient has. And after you have removed the splint, the patient is to be called for checkup after 3 as well as 6 months. So these are the 3 packs and splints that we are going to be taking care of. Next, after you have removed the nasal pack, we'll advise the patient to avoid any nose blowing for at least 2 weeks, and we'll give them nasal drops so that it prevents any crust formation at this point. And we'll also advise the patient to avoid any kind of trauma to the nose for a few weeks, avoid any strenuous physical activities for a month, and patient should not palpate their nose unnecessarily too. They should let it give it some time to heal up. So these are some basic things. And another thing that you have to counsel your patient is when the splint and the tapes are going to be removed, the nose can appear stiff and numb and somewhat swollen. So the patient should be explained this in the preoperative period itself, so that suddenly when they look at it and they have undergone a rhinoplasty and they look at their nose being such stiff and so swollen up, they may get very disappointed. So telling them that this is normal after the surgery is very important. And also because of the region of the operation, the patient may not be able to wear eyeglasses till the swelling on the bridge of the nose has subsided. And if indeed the usage of eyeglasses is absolutely essential, in that case it should be modified accordingly so that you're not causing any pressure to the bridge of the nose. Next, there are certain things that we are expecting to happen definitely after the surgery. For example, swelling and edema around the eyes. This will happen right after the surgery within the next few hours. Usually, they subside at the end of the first week. Next, ecchymosis. That will subside, it will take about 2 to 3 weeks. Subconjunctival hemorrhage, if it does happen, it will subside within 3 weeks. Dark areas beneath the eyes that can actually remain for a couple of months. And the swelling around the nose, most of it will decrease within the first 2 to 3 weeks, but it can take about 6 months for the whole swelling to subside and for the nasal tissues to settle down and soften up, etc. So, a proper evaluation of a post rhinoplasty case has to be done after a lapse of 6 months, where the soft tissues get a chance to settle down and reform in their corrected state. So, these are all things that you have to keep in mind and explain to your patient properly so that they do not have a confusion about what is happening with them. So, that's about it. And that's about the post operative care of a rhinoplasty case. Next, we'll talk about the complications of rhinoplasty. Now, complications of rhinoplasty, before we start spewing out random complications, we are going to learn how to classify the complications. So, just like any other surgery, we classify into intraoperative complications and postoperative complications. And postoperative complication in itself can be divided into early postoperative and late postoperative complications. So, starting with intraoperative complications. So, first we have here bleeding or hemorrhage. Now, bleeding or hemorrhage is basically the most common complication that we come across for any surgery. So, if you are having bleeding during the time of surgery, it can end up causing obstruction to your surgical field. So, what are the reasons why bleeding happens during the intraoperative period? First is if vasoconstriction has not been achieved adequately. When you're packing the nose, if we have not packed the nose properly, if vasoconstriction has not been achieved, that will be one of the reasons. Second, if you can end up injuring a lot of vessels. Now, what vessels can this be? Vessels can be anterior ethmoid artery, it can be septal vessels, or if the patient has some kind of underlying condition like hypertension, or say they have any coagulopathy or bleeding disorders. These are all causes why there can be bleeding during the intraoperative period. Now, in case the bleeding happens, how do we treat it? First of all, we will apply direct pressure over the area. We'll try to do nasal packing if there is a diffuse bleed occurring. If we are able to see any kind of identifiable bleeders like the septal vessels or whatever, in that case, we will perform a bipolar cautery of these bleeders. And if required, we may even need to do a ligation of the bleeding vessel. And if hypertension is the reason, controlled hypotensive anesthesia can help in this process if the patient is already undergoing a hypotensive anesthesia. So that's how we are going to treat bleeding as a complication during the time of surgery. Now, our aim has to be to prevent the bleeding altogether and not wait for it to happen. So, what are some measures that we can take so that we can prevent this bleeding? First of all, performing adequate infiltration. When you are performing infiltration anesthesia, I have discussed this in details in my previous class. You can check it out over there. Providing adequate infiltration with an adrenaline containing solution is very important. Second, when you're dissecting, being at the right plane of dissection is very important. So we have to remember to be at the right subperitoneal plane of dissection. Third, when you're handling the tissues, we have to be very gentle so that you can do not end up causing injury to the mucosa unnecessarily. So we have to perform gentle tissue handling. And lastly, it is very important to rule out any kind of coagulopathy or any bleeding disorders right during the preoperative assessment period, so that if it is present, we will control the condition before taking up the patient for surgery. So that is about bleeding or hemorrhage. Next is mucosal tears. Now, mucosal tears, we very commonly see this. This can happen, say, when you're raising the mucoperichondrial flap. If you're not careful about the plane of dissection, you can end up causing a mucosal tear. Second, if there is, say, bleeding happening and you do not have proper visualization of your surgical field, that will also lead to mucosal tears, the increased chances of a mucosal tear happening. Third, if it's a revision case and there will be a lot of scar tissue present in case of a revision case. In those cases, you have to be extra careful so that you do not end up causing any tear. So, mucosal tears can actually end up, if we have a mucosal tear on both sides of the septum exactly at the same point, that can actually end up in developing a complication later, which is septal perforation. So this is something, again, we have to be careful about, that we do not cause any injury to the mucosa and we try to limit it as much as possible. Next, in case if we do end up having a mucosal tear, how are we going to treat it? We have to reposition the flaps properly and we will repair it with the help of fine absorbable sutures. Lastly, prevention is more important. Prevention, how do we prevent mucosal tears? Again, by meticulous flap elevation and very gentle handling of the tissues inside the nose. So that's about the mucosal tears. Next, we have septal injury. Now, what kind of septal injury can happen? As I was mentioning, if you end up causing, if this is the septum and you have a mucosal injury exactly at the same site on both the sides, same side, bilateral mucosal injury will expose the septal cartilage and will lead to its necrosis and eventually lead to a septal perforation. And the risk of this is highest at the bony cartilaginous junction. So we have to be very careful that we do not end up causing this, because that will end up in another problem that we have to treat. So the primary causes here is if we have an opposing mucosal tear, or if when we are performing septoplasty, we have removed excessive cartilage, or if the patient develops septal hematoma. So septal hematoma, what can happen is, Septal hematoma can eventually lead to the development of septal abscess, and then this septal abscess can lead to development of a septal perforation. So these are all causes how the septal injury can occur. Now, what do we do? How do we treat this? If we are recognizing any injury intraoperatively, we will close one side of the tear with the help of absorbable sutures, and we will interpose a free mucosal graft if both sides are torn at the same level. So, and prevention, again, elevation of the flap in the right subperichondrial plane is very important. We'll have to preserve the mucoperichondrial flaps and make sure, if we are doing septoplasty also in the case, that we maintain adequate septal support. So that's about the septal injuries. Next, we come to osteotomy complications of bone fracture. Now, most of the osteotomy complications I've already discussed in the osteotomy video. I have a separate video on osteotomies and rhinoplasty. You can check it out over there. One of the things that can happen while performing osteotomy is that if you have not placed the cut of the osteotomy properly and it has been placed incorrectly, or you have used excessive force, that can actually lead to the development of a uncontrolled fracture. Now, when an uncontrolled fracture happens, it will end up causing either it'll cause asymmetry, or it can lead to the development of a rocker formation, and it can even develop instability of the whole region. We have to treat this by repositioning the fragment immediately and holding it with the help of an external splint. In case if the fracture is a comminuted fracture, in that case a bone graft or an implant may be also needed as a secondary procedure. Now, it is more important that we prevent this complication rather than treat it. So, how do we prevent it? When we are doing osteotomy, using the correct size of osteotome is very important, and we'll prefer to use a guarded osteotome versus an unguarded osteotome. Then, scoring the bone before cutting also helps you prevent, and we will avoid the use of any excessive single blow force. And there is a particular sequence to performing osteotomy. We are going to follow that method properly so that we do not end up causing any uncontrolled fracture in this region. So that's the next complication. Next one is cartilage over resection. So if you end up resecting too much of the cartilage, whether it is the upper lateral cartilage or lower lateral cartilage, whatever, you can actually end up causing a deformity later. Sometimes the patient ends up developing something which is known as a pinch tip deformity. So cartilage over resection is something that we have to be careful about. We only remove as minimum cartilage as possible. In case you do end up resecting too much, the treatment would be to do a cartilage graft reconstruction. And also, prevention here again is more important. We will try to do a conservative cartilage resection, and we'll try to preserve the support framework, the cartilaginous support framework of the nose. If you want to know more about what is the framework of the nose, the external nose itself in relation to rhinoplasty, you can check out my video on surgical anatomy of nose. I have explained more over there what are the relevant points. Next is buttonholing of the skin. So here, when a patient's skin is very thin, especially if this is seen in revision cases because they have a lot of scar formation, or if the dissection plane is too superficial, you can end up causing a breach in the skin envelope over the nasal dorsum or the tip. So that will lead to something which is known as the buttonholing of the skin. How do we take care of it? We will perform a primary closure with the help of a fine monofilament. And preventing it is again more important. We have to be very careful when we are in the right plane or not. The correct subcutaneous plane is important. And extra caution is needed when you are doing a revision case because they already have a lot of scar tissue formation. And preoperative assessment of skin thickness is also very important. So there's a lot of things, like especially for rhinoplasty, a good preoperative assessment is very essential. There are a lot of things that you need to look out. Like for example, the quality of the skin. Is it a thin skin or a thick skin? Because that will determine the outcome of your surgery. To know more about the preoperative assessment, again, I have a separate video. You can check it out over there. Next is CSF leak or skull base injury. Now, this is actually a very rare complication and it usually doesn't happen. But if it does happen, it can occur because when you're performing osteotomy or rasping of the bone, if you end up going too superiorly through the cribriform plate, especially when you are performing a high lateral osteotomy, you can end up causing a skull base injury leading to a CSF leak. So we are going to be careful about that. How are we going to treat it? Just like any other CSF leak, we'll get a neurosurgical consultation done. We can treat it conservatively with a head up position, bed rest, and avoid nose blowing. And also, surgical repair needs to be done. Preventing it is again more important. So, which is why in my osteotomy video, I've spoken about this, that you should not extend the lateral osteotomy above the medial canthus level. And knowing the safe osteotomy limits is very important pre-operatively. You may even mark your osteotomy cut area so that you do not deviate from it. Lastly, last intraoperative complication is anesthetic complications. Now, anesthetic complications can be hypotension from the adrenaline that you have used in your local anesthetic, or the patient having a drug allergy, or a cardiac arrest developing. Now, these are all things that an anesthetist should be taking care of or managing intraoperatively. This can be prevented by taking a good preoperative assessment so that we are able to prevent such complications during the time of surgery. So that has been all about the intraoperative complications. Next, we move on to the postoperative complications. So in postoperative complications, we can divide into early post-op and late post-op complications. Early post-op complications, we have hemorrhage, which is the reactionary hemorrhage. We can have hematoma formation, infection, edema and ecchymosis, skin necrosis, airway obstruction, olfactory disturbances, and numbness or paresthesia. We'll talk about each one of this in a little bit. Coming to late postoperative complications, we can have synecdoche, persistent nasal obstruction, saddle nose deformity, polybeak deformity, pinch tip deformity, nasal valve collapse, hypertrophic scar, retention cyst, and psychological dissatisfaction. So, moving on to discuss our post-operative complications. First, we'll be discussing the early post-operative complications. The first one we have is hemorrhage. Now, this is again a very most common complication of rhinoplasty. The reasons why you will be this kind of hemorrhage will be known as reactionary hemorrhage, which is occurring within a few hours of the surgery. Now, the cause of this is if you have not maintained adequate hemostasis, or if the patient develops postoperative hypertension or a clot has been dislodged. All of this can lead to the development of bleeding. Now, if the bleeding does happen, what do we do? First of all, if the bleeding is continuous, in that case, we apply nasal packing on the bleeding point to control it. We will avoid distorting the mobilized nasal walls at the time of packing. So, packing the nose in a case of rhinoplasty is it's something that we have to do very carefully because the nasal walls have already been mobilized by doing the osteotomies. So, you have to be very careful that you do not end up distorting what you have corrected. Bleeding vessels usually on the lower part of the septum or anomalous lateral branches of the sphenopalatine arteries at the site of lateral osteotomy would be responsible for this. So these can be taken care of accordingly. And if needed, we also perform cauterization of the bleeders. However, prevention is again very important. So, in case of hemorrhage, we will try to maintain meticulous hemostasis starting right from before the surgery itself and blood pressure control of the patient. That is why, when I was discussing about an anesthesia, I also mentioned that in case you're taking the patient on general anesthesia, in that case, hypotensive anesthesia is actually very good. It will be more helpful in controlling the BP of the patient and hence reducing the bleeding during and after the time of surgery as well. Next is hematoma. Now, hematoma, the reason why a hematoma development can happen, if you look at this image here, this is what a septal hematoma looks like. This can occur because of a reactionary bleed into the dead space which is left beneath the skin envelope or under the mucoperichondrial flaps. So you can have a hematoma under the skin envelope, or you can have an hematoma in the septal region as well. In case the hematoma formation has developed over the bridge of the nose, that mostly occurs because of inadequate fixation, and you can easily drain it at the canthal area. Now, this hematoma, if it has not been treated at the right time, it can actually end up either getting infected or getting organized. And that will lead to the dissolution of cartilage, which is why hematoma treatment immediately is very, very important. How do we treat the hematoma? We evacuate it either with the help of needle aspiration or an open drainage, and we apply pressure dressing. And if the case is infected, in that case, we also start them on antibiotics. Preventing is again more important, so we maintain meticulous hemostasis during the time of the operation and post-operatively apply a proper splint and pack for the patient. That will help in preventing the development of a hematoma. Next is we have infection. Now, infection, as I just mentioned, one of the primary causes is it can arise from the hematoma itself. So, if the hematoma gets infected, that can lead to an infection here, or there can be contamination from skin flora or nasal mucosa. And even if you're using implants in your case, in that case also the chances of infection increases. The most common offending organisms which has been found in these cases is Staphylococcus aureus. How do we treat it? We are going to use antibiotics. We are going to remove the implant if there is an implant related infection which is not settling down. And if there is a localized abscess formation, in that case, we will drain it out by needle aspiration or making a small incision. Preventing an infection is more important, so we will be starting perioperative antibiotics, meaning we start the antibiotics 1 or 2 days before the surgery and we continue it 1 week postoperatively. And if it is a case where the vascularity is compromised, in that case, we will avoid the use of implants in those particular cases. So that's about infection. Next is edema and ecchymosis. Now, as I mentioned, edema and ecchymosis is actually quite a common complication that happens where we see edema around the periorbital region and even some bruising. The reason why this happens is because of the soft tissue trauma that is caused during the time of surgery. There's a lot of manipulation and handling of the soft tissue around the external nose and the periorbital region that happens. So that is why this can lead to the development of this swelling and edema. Again, this is a complication that we do not need to worry too much about. It will settle by itself, which is why the way we treat it is in the post-operative period, we keep the patient in a prop up position so that the head end is elevated. So it will reduce the edema as well as the ecchymosis. And we also apply cold compress in the periorbital region, especially in the first 1 or 2 days. Next is skin necrosis. Now, this rarely occurs, but if it occurs, it can be because of the loss of skin viability, especially over the nasal dorsum region. The cause of skin necrosis here would be, first of all, when you're applying the splint over the nose. Excessive pressure from the splint over a very large implant or a graft can end up causing skin necrosis, and even injury to the subdermal plexus during over-aggressive defatting of nasal tip skin. That can also lead to the development of skin necrosis. How do we treat it? First of all, if we are using a explant or a trim graft to remove and reduce the underlying volume, wound care properly to be done, and if there is a reconstruction need, if it is a very severe case, in that case we perform reconstruction. Preventing this could be by doing a proper splint application, gentle tissue handling, and avoiding over defatting of the tip skin. So that's about skin necrosis. Next, we have airway obstruction. Now, airway obstruction, the primary cause here would be one is there can be postoperative edema in the case. Then, the middle vault can actually end up collapsing without the presence of any spreader grafts. And also, there can be excessive narrowing of the internal nasal valve area when the angle becomes less than 15 degrees, especially after the dorsum reduction. When you're performing osteotomies in your case, because primary reason you perform lateral osteotomy is that you narrow down the nose. So there is a certain amount of narrowing of the airway that happens with osteotomies. But if you end up doing, if you over correct the deformity, in that case, it can lead to excessive narrowing of the airway, leading to obstruction. So we treat it by using nasal dilators and revision with spreader grafts if it is persistent. And preventing it, we have to look at the internal nasal valve area, very important area. This again we have discussed in the surgical anatomy video. Looking at this area and assessing the angle is very important preoperatively. Next is olfactory disturbances, like the patient can complain of hyposmia or anosmia. Hyposmia is when there is a reduced sensation of smell, and anosmia is when there is a total loss of smell. A reduced sensation is possible in the first few weeks after rhinoplasty. Most of the time, it does disappear by itself and resolve by itself within a few months. The last early postoperative complication we have is numbness or paresthesia. Now, the patient can actually complain of a sensation of numbness in the nose, which is they start experiencing this right after the removal of the splint has been done. So this is one of those things that you explain to the patient properly, because this is something that they'll definitely encounter, and if they don't know about it, they can actually end up becoming very anxious. So that's something to be careful about. Usually this is always temporary. The nose may feel very stiff and heavy for a few days, but it will pass by itself, and within a few days or weeks, it will be completely gone. So that's about all the early postoperative complications. Last section for today, we'll be discussing the late postoperative complications. So our first complication here is nasal synecdoche. If we look over here, we can see this here is a nasal synecdoche or an adhesion that forms in the postoperative period. So these are basically fibrous bands that occur if you have two opposing raw surfaces in the medial wall as well as the lateral nasal wall. In that case, a fibrous band forms in between them, leading to the development of these synecdoche. Now, how do we treat this? If these are asymptomatic, in that case, we do not need any treatment. But if they are causing significant nasal obstruction, in that case, we have to release these synecdoche, and the raw edges are kept apart using silastic sheet for 10 to 14 days. This can be prevented with the help of proper nasal packing in the postoperative period. Next is persistent nasal obstruction. So, if the patient had a complaint of nasal obstruction as well when you're performing the rhinoplasty, if the nasal obstruction doesn't improve at all despite doing the surgery, that is one of the complications. Reasons could be either there is already a residual septal deviation that has not been corrected, or some synecdoche or adhesions have developed, or there has been a nasal valve collapse. There can be multiple reasons over here, or maybe there's septal hematoma development. All of these can cause a persistent nasal obstruction. The way to treat it would be to identify the cause and correct it surgically. Next is saddle nose deformity. Now, this is very important. If we look at over here, this is what a saddle nose deformity looks like. You know how a saddle of the horse where you sit on goes like this, right? This is the part where it dips. That's exactly what happens in the nasal dorsum region. So, there is a loss of support of the nasal valve and a subsequent collapse that occurs, leading to this particular type of deformity. The reasons why this can happen is if you have resected excess of the septal cartilage, or you have when you were correcting the dorsal hump, when you were reducing it, you did an excessive dorsal hump reduction, or in cases of septal hematoma, septal abscess, or severe nasal trauma. Treatment would be to perform an augmentation rhinoplasty using an autologous cartilage graft, and we usually prefer the septal cartilage or the auricular cartilage. To preventing this, we preserve at least 1 to 1.5 centimeter L strut of the septal cartilage when we are performing septoplasty. So I have discussed all about septoplasty more in details in a separate video. I'm linking it above. You can check it out over there. When you are also correcting the dorsal hump, we will not perform over resection of the hump, And when we are resecting the septal cartilage, we will again be very conservative about how much we are resecting. Next is another deformity which is known as polybeak deformity. If you look at this image over here, this is what a polybeak deformity looks like. It basically looks like the beak of a parrot. That's why it's known as a polybeak deformity. So what we are seeing here is we are seeing a excessive fullness in the supratip area, making the nose look like as if it's a parrot's beak. So we all know how a parrot's beak looks like. The reason why this develops is if there is a failure to maintain an adequate tip support. If the tip support system has been destroyed, in that case, it can lead to this. If there has been an inadequate cartilaginous hump and anterior septal angle removal, if we leave behind dead space in the supratip region, and if there is any scar tissue accumulation. Treatment of this would be requiring a revision rhinoplasty where we correct the reduction of the cartilaginous dorsum and the septal angle cartilage region. And we also excise of the soft tissue scar if it is present, and we fix the columnar strut region. Preventing this is more important again, so we provide adequate supratip cartilage reduction. We avoid leaving any dead space in the supratip area, and we maintain adequate tip support. So that's about polybeak deformity. Next is a pinch tip deformity where there is a overly narrow constricted nasal tip. This I was already mentioning earlier how this can happen because of excessive alar cartilage resection. That can end up leading to this pinch tip deformity of the nose. The way to treat it would be to do a cartilage grafting, and preventing it is by doing a conservative tip surgery and not over resecting the cartilage. Next is a nasal valve collapse. Nasal valve collapse, a dynamic collapse or a static collapse can happen of either of the internal or external nasal valve, and that can lead to the development of nasal obstruction. Cause of this is loss of structural support in this region and excessive cartilage removal. And treatment of this would be to use spreader grafts or alar batten grafts. Prevention is by knowing the valve anatomy well and paying attention to that region by not causing a structural support damage in that area. Next is hypertrophic scar. Now, with any kind of incisions, there can be a possibility of a hypertrophic scar or a keloid development. This can happen at the transcolumnar or the alar incision site. These two are the incisions that we give in a external rhinoplasty, and this is more commonly seen if there is poor wound tension alignment. So, knowing how to precisely oppose the skin edges with the help of everting sutures is very important, and to maintain gentle tissue handling. And treatment of this would require an intralesional triamcinolone injections and scar revision if needed. Next is retention cyst. Sometimes over the nasal dorsum region, you can end up developing a cyst-like structure, which is a retention cyst. This can especially form at the lateral osteotomy site if you have used a saw and there is bone dust or chips left behind. So retention cyst forms around this bone dust. So it is very important to prevent it by always sucking over the osteotomy lines, especially if you have used a saw. Lastly, is psychological dissatisfaction. This is something that can only be prevented by proper choosing of cases as well as proper counseling of patients. So, this occurs when the patient has unrealistic expectations from the surgery or if they have an underlying body dysmorphic disorder. So, even if the results are objectively good, the patient will not be happy about it. So that's something that you can prevent by doing a proper counseling in the preoperative time. And it is also important that you take standard photographic documentation during the preoperative period in case you face some kind of a lawsuit because of that. And if you are suspecting body dysmorphic disorder, in that case we decline surgery. Treatment of this would require to send the patient for a psychiatric referral, counseling, and CBT, and avoid any revision surgery if you are suspecting body dysmorphic disorder. So that's all about this. All about the complications of rhinoplasty. If you have any doubt regarding this, please note them down in the comment section and I'll get back to you. Thank you.